Good morning everyone. Today I discuss about the topic regarding endoscopic retrograde cholangiopancreatography. I am Roslyn Anita, nursing tutor in Tribhuvan College of Nursing. Objectives are introduction, definition of ERCP, list down the purposes of ERCP, mention the diagnostic uses of ERCP, list down the therapeutic uses of ERCP, list the articles needed for ERCP, preparation of patient for ERCP, explain the procedure of ERCP, and list the post-procedure care of ERCP, state the complication of ERCP, list the contraindication of ERCP, what are the advantages and disadvantages of ERCP, imaging the abnormal finding in ERCP. Introduction. Endoscopic retrograde cholangiopancreatography. ERCP is a combined endoscopic and fluoroscopic procedure in which an upper endoscope is let into a second part of the duodenum, making it possible for passage of other tools via the major duodenal papilla into the biliary and pancreatic duct. Contrast material may be injected in this duct, allowing for radiological visualization and therapeutic interventions when indicated. ERCP initially started as a diagnostic procedure through cannulation of the pancreatic and biliary ducts, but has evolved over the years to a predominantly therapeutic tool. Definition. Endoscopic visualization of the common bile, pancreatic and hepatic duct with a flexible fiber-optic endoscope inserted into esophagus, passed through the stomach and duodenum and into common bile duct and pancreatic duct. Purposes: to diagnose obstruction in cholangiopancreatic tree, to detect extrahepatic biliary obstruction, and to diagnose pancreatic diseases, to determine nature and level of pathology in biliary obstruction, and to evaluate pre and post-operative conditions of obstructions. Next, we'll see the diagnostic uses of ERCP. Obstructive jaundice, chronic pancreatitis, gallstones with dilated bile ducts on ultrasonography, bile duct tumors, pancreatic tumors, suspected injury to bile ducts, either as a result of trauma or iatrogenic. Coming to the therapeutic uses of ERCP, endoscopic sphincterectomy both of biliary and pancreatic sphincters, and remove of stones, insertion of stent, dilation of stitches, example primary sclerosing cholangitis, anatomic stitches after liver transplantation. Articles needed for ERCP: side viewing duodenoscope, ERCP catheters, X-ray compatible table, contrast medium. Coming to preparation of patients. Preparation and rationals. Explain procedure to the patient and confirm that an informed consent has been taken from the patient. It allays the anxiety and help in obtaining the cooperation of the patient. Get informed consent from the patient. Prevent the legal problems. Assess for any allergies to iodine and seafood. Contrast medium usually contain iodine. And explain to the patient that he will experience a flushing sensation during administration of contrast medium. Prepares patient for the procedure. Instruct patient to be NPO at least 4 to 6 hours before the procedure to prevent aspiration during procedures and ensure that artificial dentures are removed. It will prevent possibility of loose dentures abstracting or way. Monitor vital signs and observe level of consciousness and tolerance of procedure. It obtains baseline data for comparison in future. Administer antibiotic as added. Act as a prophylaxis against post-procedural infection. And administer sedatives, glucagons or anticholinergic as added. Glucagon stops duodenal peristalsis. Anticholinergic reduce secretions. Sedatives reduce anxiety and help in relaxation of patient. And spray the throat with xylocaine or instruct patient to gargle and swallow topical anesthetic agent. It decreases gag reflex. Coming to the procedures, place patient in left semi-prop position and inform that multiple position changes are required during the procedure. Rationals enable easy passage of the endoscope and enables effective radiographic visualization and observe the patient for any adverse effects of medication administered like respiratory depressions, CNS depressions, hypotension, vomiting, etc. And monitor IV fluids administered during procedure and help in changing position as required. It will help for sedatives may induce the side effects like respiratory depressions, CNS depressions, hypotension, vomiting, etc. Position changes may be required for radiographic visualization. Record events of emesis, respiratory distress, vasovagal reaction or diaporesis. It will help to know the adverse effects. And document all drugs administered, stents placed and biopsies taken in nurse's record to promote communication among healthcare workers and record the fluid administered, techniques used and patient condition at the end of the procedure. It helps to identify patient's tolerance to the procedure. Coming to the post-procedure care. After procedure, monitor vital signs and level of consciousness. Position patient to prevent aspiration and transport to recovery area. Observe and report abdominal distension and size of perforation, gastrointestinal bleeding or signs of possible pancreatitis including chills, fever, pain, vomiting, tachycardia and notify physician immediately. And maintain NPO status until gag reflex returns. Check for gag reflex by applying gentle pressure using a tongue depressor placed on the back of the tongue. Give verbal and written instructions to patient and relatives regarding diet, medication, activities and possible complications. Instruct the patient to drink ample amount of fluid after administration of the dye. Warn the patient that there may be some discomfort with urination while the dye is excreted. Complications: pancreatitis, pleural effusion, gastrointestinal bleeding due to cervical perforation, esophageal perforation. Contraindication of ERCP: acute pancreatitis, previous pancreatidodenectomy, coagulation disorder if sphincterectomy plan, recent myocardial infarction, history of contrast dye anaphylaxis. Coming to the advantages of ERCP: safe and highly effective diagnostic technique, accurate method of diagnosing and treating condition of the bile and pancreatic duct. Similar than explanatory surgery, can prevent the need for major abdominal surgery, may help with planning for surgery. Disadvantages of ERCP: possible complications include bowel perforations or hemorrhage, which might require surgical repair of blood transfusion respectively. Risk of perforation or hemorrhage is increased when polyp are removed via the endoscope. The procedure requires a hospital stay. Sedation is required with a small risk of adverse reaction to medication used. There is a degree of patient discomfort. Abnormal findings in ERCP: ERCP with perforations. This picture shows primary sclerosing cholangitis. This picture shows choledocholithiasis. Coming to the conclusions, ERCP is one of the highest risk endoscopic procedure performed by GI physician. The indication should be carefully considered and less invasive alternative should be pursued if feasible. The lesser than the indication, higher the complication. Proper informed consent is essential to patient empowerment and medico-legal documentation. References: you can refer quality indicator for ERCP gastrointestinal endoscopies and J.D. Lewis ERCP, the Journal of Clinical Gastroenterology, and SlideShare.net and eMedicine Medscap. These are the references. Thank you.